Hello and welcome to Bottom Line. I'm Cindy Keynes. We have a great informative show for you today. We're going to talk more about what is acid reflux, some of the signs, symptoms, and treatments and prevention. I'd like to introduce my guest for today's show, Dr. Mark Herman. He is with the Beaumont Health Systems. Welcome, Dr. Herman, to the show.
Thank you very much for having me.
Well, you know, everybody, acid reflux, and I think, people say I have indigestion, acid reflux, maybe it's true, maybe it's not. Maybe you can help us understand what's considered acid reflux.
Yeah, acid reflux, or GERD, as it's commonly referred to as gastroesophageal reflux disease.
Which GERD's a nice shortcut.
Exactly, it's much easier to say, or just reflux. And I think it's something that most people can relate to some extent or another. I think almost everybody at some point gets a little bit of acid reflux or heartburn. Mm-hmm. So it's commonly heartburn that people get, the burning sensation beneath the chest, up in the neck, acidy sensation that may wash up into the mouth, almost a regurgitation type of a symptom, sometimes a little discomfort with swallowing.
Okay. Now, many of us, like you said, probably, I would assume that this is something that most times happen as we get older in life, that we start feeling these symptoms come on.
It can. In fact, newborns can be born with it, especially if they're more premature. I don't treat the children, I treat adults for this. But yeah, certainly with age it gets to be more problematic for people, but we do see it in all age groups. Okay. There are some additional symptoms that people get as time goes on that may not be immediately thought of as being from reflux disease. So the symptoms I just mentioned are the typical symptoms which people get, but there are some atypical symptoms, and those are more respiratory pulmonary symptoms. So people who have a chronic cough, people who have a sore throat or hoarseness of their voice or voice changes, even wheezing or asthma-like symptoms that progresses over years can actually be from acid reflux getting in the airways and the lungs and may not truly be acid or lung problems.
Right. Which is interesting because those things that you said you wouldn't have thought normally are related to acid reflux and that. And when somebody has this and they experience this, what might be an idea that this is something that is serious and maybe they should get it checked out versus maybe over the counter?
Yeah, that's kind of the hard decision making there, and there's no set hard and fast rules for that. But in general, if you're taking some antacid medication over the counter, be it Tums or some of the over-the-counter Prilosec, Prevacid type medications that are available now, if you're taking those on a frequent basis because the symptoms are bothering you frequently, maybe it's daily, every other day, and it's really starting to affect your comfort level and your lifestyle, you need to work with your primary doctor to then have it investigated further.
Okay. And when we think of what's normal too, if someone's having, something with pizza or spaghetti sauce or some kind of tomato sauce, something that's spicy for them one night a week, that's not something that should be considered serious once or twice a week if you're having that.
No, probably once or twice a week is not that problematic. But more than that, then you should have your medical doctor look into it.
Okay. And if we talk about someone who's having maybe some of those symptoms, maybe they're on the cusp of should I go to the doctor maybe once or twice a week, what are some things that they can do to avoid that? Of course, avoid the food that causes it. I guess that's probably, but what might be some triggers? What foods might trigger someone having acid reflux?
Sure, there are some well-known triggers, and the first thing that we always recommend to patients are what we call lifestyle modification changes. And those are the hard ones because they're habits that we get into that are hard to break. But things that really aggravate reflux are alcohol. So really limiting alcohol consumption.
And why is that? Why alcohol is?
It has an effect to loosen the sphincter mechanism between the esophagus and the stomach. And anything that loosens or relaxes that can cause the acid to come back up. Okay. Other things would include nicotine. So smoking can aggravate it. Caffeine is also a big trigger for people. So really limiting caffeine in any form, and it can be insidious sometimes. You don't necessarily think that your soda pop or your energy drink is going to have caffeine, but you want to try to avoid caffeine in any form.
Okay. And if you mentioned like caffeine, if someone has caffeine pop, that might be an alternative. I mean, maybe there's a small amount of caffeine, and even caffeine-free, is it?
Caffeine-free beverages should be okay. It's really the caffeine content that tends to be a problem for folks.
Okay.
So minimizing that. And then the other thing that goes along with it is not so much particular foods. It may not be the spaghetti or the sauce, because that can vary individually. Some people react differently. But it's a healthy eating lifestyle that you want to try to adhere to. Weight is a big problem in our society. We know that, and weight plays a big factor with acid reflux. So people who tend to be overweight tend to have problems with reflux. And if you can keep your weight under a normal range, then the reflux will get better as well.
Okay. Now, many times I think many of us too, after you have a big meal, large meal, you kind of feel like there could be heartburn. Why is there something maybe why we feel it more after a large meal than maybe a medium size or a normal size where we overindulged?
Sure. If you think about it, your stomach is just a large sack, if you will, to accommodate whatever you eat. And if you over-distend it and overstretch it, it's going to want to come back up. And so we do advise that you avoid eating prior to bedtime. Okay. And if you think about it, if you lay down flat, then it's easier for gravity to allow the contents of the stomach to come up into the chest or the esophagus. So you want to avoid going to bed and laying down with a full stomach.
Okay. And what are some things, at night we can do, again, not eat right before we go to bed, but can you lift your head up, lift your body up a little bit, to raise it? Would that kind of help that way you're not laying flat?
Yeah, absolutely. We'd recommend that as well. Raise the head of the bed. Practically speaking, that can be done with some pillows, not ones that are too soft that you then smush back into them, but some firmer pillows. And some people have even resorted to putting some type of supports under the posts or the feet of the bed to raise the whole bed up at an angle.
Okay. And is this something that could be hereditary you get from your parents? If they had acid reflux or GERD issues and things like that, that maybe you would?
Not so much. I don't think there's a known real strong hereditary component to it.
Okay. And can you think of anything else that somebody might, now you mentioned some symptoms in that, but there's some things else that maybe we might eat that we might not think that, well, this is something that might be pretty acidic and affect you negatively?
There's a lot of rumors, I think, and maybe misperceptions about certain foods people should eat or not eat. I think for reflux, there's a little bit of trial and error in that in any individual. Yeah. So if there are certain things that are bothering you and triggering your reflux, it might be a little bit different from somebody else. So it's really hard specifically to say, but common sense just dictates that if there's a certain thing that bothers you, try to avoid it. Yeah. But we do know those big triggers that I mentioned before, the nicotine, the caffeine, and alcohol are really
huge.
The big three.
So as a surgeon, when someone comes to you and says, Dr. Herman, I think I've got these symptoms, and that, first do you treat them by trying to see if they can make these lifestyle changes, and then if it continues, what might be the next steps?
Yeah, so if the lifestyle steps haven't really helped much, then there's some medication options that people can then resort to, prescription strength medications. Okay. The prior class of medications were called the H2 blockers or histamine blockers. Commonly on the market, they're Zantac, Tagamet, Pepcid, and they worked very well. Their efficacy has waned a little bit through the years, and they're about 60% effective for people. The new class of medications called proton pump inhibitors, or PPIs, are the Prilosec, Prevacid. Some of those are over the counter now as well, but those are much more potent antacid medications, and those are better than 90% effective. Okay. So they work very well.
So then if someone can try those, you try maybe over the counter if they can do it, then after that you kind of step it up to maybe a prescription version. And then if it's still, in the small amount of cases after that, what happens then at that point? Yeah,
the prescription version should be taken every day, not just when you need it, but every day, because that will actually stop the acid from being produced by the lining of the stomach. If you're still having symptoms, or if you're at that point where you're needing prescription management for your reflux, I also recommend that patients have an endoscopy, so an EGD is a scope to look at the lining of the esophagus and the stomach. The importance of doing that is to confirm that there is indeed reflux present and that there isn't some other underlying condition or complication of the acid reflux disease.
Now, when someone would do one of the tubes down the throat and that's after they've tried over the counter and they've tried some of these other medications. You just don't normally want to have somebody have a scope down there.
No, not everybody who has occasional periodic heartburn is going to need a scope.
Okay.
But if you're at a point where you're needing prescription management for it, I think you should have the endoscopy to look. And the reason being is that reflux can result in some complications. It can lead to inflammation or irritation of the esophagus lining. It can lead to scarring developing in the lining of the esophagus, which can narrow it and block it and make it hard to swallow. In cases patients who do have inflammation, it can result in what's called Barrett's esophagus. So 10% of patients with reflux will have Barrett's esophagus with it. And that's an abnormal change in the lining of the cells of the esophagus. And that can subsequently predispose people to develop cancer in those areas.
Okay.
Now, it's very rare, it's uncommon, but that's the importance of having the scope, is to make sure you don't have precancerous conditions or hopefully not cancer.
Okay. And if somebody at home says, well, I get it, and I do the over-counter, it doesn't work the greatest, but I'm not going to the doctor, I don't want to worry about surgery, I don't want to go down there. What might be the path that they're leading down if this goes for a long time untreated? I mean, treated somewhat, but still there might be more damage going on if people keep waiting. What could happen to those folks that wait too long?
Yeah, and those folks with the lining of the esophagus becoming damaged, again, it can become inflamed, it can become raw. Potentially it can ulcerate or bleed. It can scar or stricture and cause a blockage, and in rare cases cause inability to swallow. So solid foods might have trouble actually passing. And then there's the risk of developing precancerous changes to the esophagus or cancer.
So better be safe than sorry, maybe.
Absolutely.
If you give it a try with some over-counter, maybe just one quick doctor visit might help.
Hopefully so, yeah.
Now, we talk about acid reflux and the body and the acid. Again, the purpose, I believe, and I was going to verify with you, of course, is that acid gets developed in your stomach to help break the food down. And then with that, is there something that maybe causes too much acid? Is it something we eat or do that might cause too much of the acid production?
There are very rare conditions that people can have where the body creates too much acid. There's growth tumors called gastrinomas that can occur in the upper intestinal tract, and they're very small little tumors that can cause hormones to be secreted, which then cause overproduction of the acid.
Okay.
So those conditions do exist. They're very rare, and they're more prone to cause people to have ulcerations of the stomach rather than symptoms of acid reflux so much.
Okay.
In terms of the reflux, we don't look too much to work up people for overproduction problems.
And what about stress? How does stress relate? Sometimes maybe people feel more heartburn or some acid or something, maybe in just when they've been stressed, maybe work, the family life, whatever might be happening.
Yeah, so stress can be a part of aggravating reflux potentially, or symptoms of stress could mimic reflux symptoms with tightness in the chest, maybe some burning in the chest, some discomfort there. And that may not really be reflux, it may be symptoms of stress. Some people's stress is manifest maybe as headaches. Well, that doesn't mean they've got a brain tumor, nor does chest discomfort necessarily mean that they have reflux. So patients who we're looking for surgery as an option, we have them undergo some additional testing. And we actually measure the level of acid in the esophagus that they are refluxing. That way we can quantitatively measure, yes, you are refluxing, or no, you're not. Maybe it's just attributable to stress.
And hopefully then they can manage that and not have to go further down the road of surgery and avoid that path.
Correct.
Now, you mentioned, if you have a patient, they've tried over the counter, they've tried prescriptions, now you put a scope down. Now, when you put a scope down, is that just a one-time where something gets to look inside, or do they wear it like a heart monitor for a while to see what happens over a 24, 48-hour period of time?
A couple of different things in that question. The first is the scope, the EGD it's called.
EGD, okay.
And that's something that I refer to my gastroenterology colleagues to do. I don't do those myself. Okay. That's a quick outpatient procedure under some sedation that just examines the lining of the esophagus and the stomach to look for the things that I had mentioned in terms of ulceration, inflammation, or growths, and things can be biopsied with that procedure as well. So that just may only need to be done once to make sure there aren't any complications of reflux that the patient has. If they do have Barrett's, then it's biopsied and they will need to have repeat endoscopies to assure that that area heals or doesn't progress into something more serious. So the endoscopy can vary a little bit on how frequently it's needed. The other testing that you're referring to would be the monitoring of the acid that people are refluxing. That can be done during an EGD test. The gastroenterologist will attach a small electrode on the lining of the esophagus. It's called a Bravo test, B-R-A-V-O, and that little electrode will then record the amount of acid that one is refluxing over the 2-day period of time while you're at home going about your normal day-to-day activities.
Do you even feel you have it?
No, you don't. You shouldn't even know you have it, and after a couple days it passes on its own.
Oh.
And it transmits data to a little receiver, and then that's interpreted, and it will then give us a hard score of the severity of your acid reflux.
Okay. Wow, that's amazing. And you put it in and out it goes at one point, and you never know the difference.
Yeah, that procedure is kind of replacing our old procedure, which was called a 24-hour pH probe test. That test involved a small catheter which was passed nasally into the esophagus, and it was secured in place for 24 hours at home while you're going about activities. That was a little more uncomfortable for people because it is a catheter passed through the nose. And it's not painful, but it's not the most pleasant experience necessarily either. And the current Bravo test is much more patient-friendly.
Yes, exactly. And you get probably just as good of data.
Exactly.
Okay. If someone goes through, some of these tests and they find out it is acid reflux, then what do you do next? What kind of surgeries? I mean, what would somebody expect, and how do you approach that?
Yeah, the surgery is designed to recreate what's called the lower esophageal sphincter. So there's an actual sphincter muscle which is present where the esophagus ends and right where it joins the stomach. And that is tight enough to prevent acid or stomach contents from refluxing up. If that becomes dysfunctional, such that it's loose and not working, people can tend to have reflux. So the surgery is designed to recreate that sphincter mechanism. So we actually take part of the stomach. The stomach's kind of a floppy organ, and it has enough redundancy to it that we can take part of it and actually wrap it around that esophagus area to recreate that sphincter mechanism.
And then allows it to keep it a little tighter then.
It keeps a little bit
tighter. Not too tight, because you want to be able to...
Exactly. So that's one of the things we have to do is do the surgery with that wrap being loose enough so you can still swallow well, but tight enough that things won't back up on you.
And what happened now after you do a surgery like that? I know you're trying to do it on a permanent basis. Does something happen where at a certain point even that starts getting, looser?
Yeah, that's a good question, and I think that's been one of the criticisms of this surgical approach. Not everyone's a huge fan of doing a surgical approach for reflux, and one of the criticisms is that over years the efficacy of the surgery might wane. And data has shown that up between 5 to 10 years after surgery, most people have good control of their reflux still. We're talking upwards of 80% of patients will still have good control of their reflux. Out beyond 10 years, we don't really know because studies haven't followed patients that long really to know. But there is some suggestion that with time, people's symptoms might start to recur and maybe they'll start to require some medications again. But when you survey those patients in the future and ask them how happy they were with their surgery, they're all very happy and pleased. Satisfaction scores are extremely high. So my analogy to that is it's a little bit like having a knee replacement. The arthritis in the knee isn't life-threatening for you. Reflux typically isn't either. It's a lifestyle decision. And if that knee is very uncomfortable for you to undergo replacement, you're going to feel much better for a longer period of time. Is that knee replacement going to last forever? Maybe not.
It depends, you know, and everybody's
Yeah.
individualist and what's their life like and how the surgery went, what's their health like. Yeah.
Exactly.
Yeah. So hopefully at least those things can be, and what happens during the surgery? Is that within an hour or two that takes that kind of time to do a surgery like that? And what's recovery after that?
Yeah, the surgery takes about 2 hours, and it's done usually with an overnight stay in the hospital. Traditionally, it was done open, and the surgery's been around a long time. It was originally described in 1956 by a surgeon named Nissen, and it still bears his name, a Nissen fundoplication. And it used to be done open with an incision in the upper abdomen back when I trained. That's how we did it. Then it's transitioned to being done laparoscopically, and that means with a small camera and generally 4 to 5 small incisions in the upper abdomen, which makes recovery quicker, the incision's smaller, pain is less. And now I've transitioned into doing these robotically, which has the advantage of those same small incisions. But for me as a surgeon, the optics are superior, the instrumentation is very precise, and I think personally I'm able to do the surgery a little more efficiently and a little more quickly, so hopefully it'll be better for the patient.
Right. And when you do robotic and you know you have the incisions, how do you, you know, I'm trying to guess imagine it as, because you say you take kind of the stomach and the redundancy and kind of wrap it around that sphincter area there. How do you do that? How does it manage to do that? Will you actually lift the stomach and turn it around with just the robotic hands and these incisions?
Exactly. We create some space behind and around the esophagus. And again, the stomach is floppy and loose enough and redundant enough that it'll reach around behind and wrap around. And then we just sew it back to itself, not unlike a pleat, sort of, and sew it back to itself and suture it back to itself, and that holds it in place. And it's doing some of that suturing and maneuvering that's much easier with the robot instruments.
Robotic, yeah. And then what's the recovery time for someone? Like you said, they might be in the hospital overnight, but then what are they? Can they be back and active and walking and running in sports a week or two later, or just?
Exactly, within a week or two. So I ask my patients to follow up in the office within 1 or 2 weeks. And if they're feeling good in terms of pain and discomfort, and if they're eating and swallowing well, they can go about doing whatever they'd like.
Right. Now, you know, prior to the surgery, acid was backing up because they had some issues with that. So maybe they were avoiding, you know, caffeine and alcohol and nicotine and some of those things, which probably are not bad to avoid anyways from a health standpoint. But after surgery, could they go back and, you know, have caffeine, maybe drink caffeine and coffee or something, because now what was causing them problems wasn't, you know, it was now fixed, hopefully?
Yeah, ideally they should be able to. Sure, they can go and enjoy their coffee or their glass of wine and hopefully not have the same symptoms.
Same symptoms in that,
yeah. And most people who have the surgery, better than 90%, are able to stop their antacid medications completely.
That's what I would hope, you know, they could get back to that.
Yeah.
And then is it something that, and I know you said you're following patients 10 years, maybe 15, 20 years, if they start feeling the reflux, maybe that's again the time that they have to look to have maybe another procedure done possibly.
Yeah, the surgery can fail.
Yeah.
There is a certain incidence of patients who just don't respond to the surgery.
Yeah.
So that's known, I guess, like any surgery, but those are uncommon.
Right.
There can certainly be some technical failures of the surgery that arise, and that would require some additional testing and possibly a revision surgery. But generally with time, if someone's symptoms are just starting to creep in again a little bit here and there, then they might need to take an antacid from time to time.
Right, and hopefully not go the route for another surgery.
Exactly.
Now, do you see your patients, would they be older now? You know, I'm just kind of imagine, you know, unfortunately, as we get older, the body starts, you know, losing some of its strength and some of the things happen, we start breaking down more. So is this something where more of your surgeries are in older patients?
I've seen a lot of different variety of patients. So the thing that I do see in older patients are hiatal hernias more. And a hiatal hernia is something which is commonly associated with reflux, but isn't necessarily causative of the reflux itself. And it can be seen with the scope. They look in the stomach and see a hiatal hernia. And what that is it's a little hole or widening of the diaphragm muscle that separates the chest from the abdomen.
Yeah.
And the esophagus has to pass through that muscle to get into the abdomen to the stomach. And if that muscle starts to widen, then the stomach can actually slip up into the chest.
Okay.
When that happens to a small extent, it's not a big deal. It's very common, and it frequently happens with age. As that hole gets big enough, actually the entire stomach can herniate into the chest and cause significant symptoms, which might mimic reflux in some patients. So that's the sort of thing that I see in older patients.
Okay. And is that easily fixed also?
It's fixed in a very similar way.
Similar way?
Very similar way. We just pull the stomach back down where it belongs, basically. We do the anti-reflux wrap, and then we also use sutures to close up that hole in the diaphragm at the same time.
Okay. And now, a hiatal hernia, is that just based because of age? It's our age and that some things start happening, or is it because of reflux and a little bit of both that causes it?
Typically age. Age is a thing like hiatal hernias. I equate them a little bit to like gray hairs. You know, as you get old enough, you're going to get some gray hairs, and you're going to get a little bit of a hiatal hernia. And in most cases, it's inconsequential.
Yeah. So as we kind of wrap up the show here, and you think about for our audience, are there some maybe words of wisdom that you would share with them as they think about, do I have acid reflux? Shouldn't I go? Should I talk to a doctor? Or I'm kind of worried they don't, maybe they're afraid to go to the doctor, what he or she might say. Yeah,
don't be afraid to see your doctor about it, especially if you're being bothered with it frequently. If it's affecting your lifestyle, if it's affecting your comfort, then you should definitely get checked out.
Okay.
And that's going to vary a little bit from person to person. Maybe it's once a week is driving you crazy with the symptoms. Maybe it's every day. But if it's enough that it's bothering you, go see your doctor.
Right. And are you seeing an increase in this in younger people maybe? Because, I always think now of younger people and the challenges they have, or stress, or a little bit of everything, or the energy drinks, the caffeine, or something that maybe you'll see younger and younger patients.
Yeah, and I think that's, again, related to weight issue. Our society has become fairly overweight and at a younger and younger age, and so with weight comes problems with acid reflux. And in fact, patients who I see who are significantly overweight to a point, then surgery may not be a good option for them.
Yeah, and that's kind of a shame then too, and then more complications. So, well, Dr. Herman, thank you very much for being on the show with us today. I think that gave us a lot of great information and helpful for people to kind of know that there's if you have to go surgery, it's not so drastic.
No, very well tolerated.
It's amazing now with robotic and how quick you can recover and get back to being normal. So thank you again for sharing your expertise with us. I thank you for watching us join us today. I wish you the best of health. I'm Cindy Keynes.
Thank you.